to all our speakers and all the delegates who have joined us for this impactful CME organized by SIG Endometriosis and SIG Counseling. It's a unique combination that emphasizes not just the clinical experience, but also the communication needed to support our patients. So I would like to call Dr. Sabina Singh, co-convener SIG Endometriosis, to give the welcome address. Ma'am, over to you.
Okay. So thank you, Soumya. Good evening, everyone. I welcome you all. So as we know that endometriosis is a chronic condition, and if 40% of these patients are associated with infertility, they are fighting with infertility, then in a recent survey, around more than 2/3 of these patients have certain psychological issues which are often neglected. The worst part is these women, maybe because of the social stigma, or maybe they are unaware whether they are normal symptoms or abnormal, they are very much hesitant to consult a psychologist or any counseling session. So today, SIG Endometriosis and SIG Counseling and Patient Support, we bring you a very beautiful and interesting lectures with our eminent speakers. And I welcome you all. So now, before wasting much time, I'll start. Shweta ma'am has joined. Shweta Mittal ma'am has not joined. Okay, so we can directly start with our first session. For this, Rahul CV, can you please move to Dr. Nair City? So for the first lecture, I would like to invite Dr. K.D. Nair, sir. Sir needs no introduction. He is Senior Consultant and HOD, Akanksha IVF Center, New Delhi. Immediate past President IFS, Convener Education Committee, Chair-elect, and Chair IFS Guideline on Poor Ovarian Response 2024. Sir has various international and national publications and presentations, and he's the receiver of a Star Award for the consequently past 5 years. So I welcome you, sir, and thank you so much for joining. So I would like, sir, if you can invite Dr. Lakshita. Dr. Lakshita is, yeah.
Yeah. Good evening, everybody. It's a pleasure to be part of this webinar. And I like to invite Dr. Lakshita Sharma. She is Associate Professor and Head of Amity Medical School, Dietetics and Applicable Applied Nutrition from Amity University. She is a member of Nutrition Society of London and Executive Director of Hindustan Agriculture Research Welfare Society. She has more than 19 years of experience and a lot of publications, and she has been awarded Women Scientist Award by Government of Gujarat, Asian Foundation Award, recipient of Excellence in Outstanding Accomplishment by various societies. She has delivered international guest lecture at Dubai and University of Malaysia, and she is an active member of Journal and Research Community. She is on the editorial board member of International Journal of Nutrition and Agriculture Research, and peer scientist in the. She's a peer scientist there, International Journal of Nutrition and Food Sciences. Welcome, Dr. Lakshita. We are waiting to listen to your talk.
Yeah, thank you so much, sir, for such a nice introduction, and a very good evening to all the esteemed colleagues here. So I hope my voice is clear.
Yes.
Yes, okay. So I'll just share my presentation so that I can brief the topic, and we would be talking about the nutrition aspect. I know you know what endometriosis is, and the most of the population suffers from this disease, but the nutrition aspect is really untouched, and most of the nutritionists do not touch this topic, and also we don't prescribe certain diets for this disease. But let me tell you that nutrition has a major role in women hormonal health.
Hello.
And yes, sir. Am I audible?
Yes, we can hear you.
So just a brief introduction, I'll start with the disease, that it is a chronic non-cancerous gynecological condition and characterized by the presence of endometrial tissue outside the uterus, commonly affecting the ovaries, fallopian tubes, and pelvic lining. So I know we have doctors among us, so I don't need to explain the definition of endometriosis, but it has certain symptoms that are not bearable for the women around, and it is a life impacting pain that occurs during period, sexual intercourse, bowel movements, urination, pelvic pain, abdominal bloating. So there are many symptoms are associated with it, and it is a very painful condition for certain women who suffer from endometriosis, and it is under the influence of hormones. So it is the tissue that is located outside the uterus. It thickens, breaks down, and bleeds each month. The blood cannot exit the body. Blood becomes trapped, it becomes cyst, or it irritates the surrounding tissue. The result is the pain or the infertility. So this is a brief about the disease that occurs. Then comes the severe symptoms that a woman experiences, and the outcome of the disease can be infertility also. That is again very painful: fatigue, constipation, diarrhea, depression, pain after sex, pain during menstruation, chronic pelvic pain, depression, fatigue, heavy menstruation, severe period pain. These all are the symptoms that are not easy for women to bear, and the day-to-day life is impacted due to this disease. So it is a complex disease, and many different factors contribute to this. And what we'll talk today about what are the causes of the disease and how we can, what is the, we have to understand the pathophysiology of this disease and how nutrition can support the women who are suffering from this disease. So we say that many different factors contribute to its development, and it arises due to the especially when menstrual blood containing endometrial cells flows back towards the fallopian tubes into the pelvic cavity. At the time of that, blood is flowing out of the body through cervix and vagina during periods. So retrograde menstruation can result in endometrial like cells being deposited outside the uterus, where they can implant and grow. So cellular metaplasia is another factor, where the cells outside the uterus change into endometrial-like cells and starts to grow. Stem cells can give rise to disease, which can then spread through the body via blood and lymphatic vessels. Then potential causes are the genetic links passed through the families, retrograde menstruation, certain surgeries, hormonal issues, immune system disorders, which is nowadays can brought about by the pathogens also, cellular metaplasia, blood or lymph system transport. So these are the major factors. And there are, epidemiological factors also. That is the heredity and environment. The Charles Darwin very truly said that the heredity and environment are very much responsible for the development of many diseases, not only this one. So the personal habits affect a lot. Like if alcohol drinking is on rise, the diet is inconsistent, there is a lack of regular exercise. So these are the major environmental factors. Then the risk factors that are involved: starting your period at early age, never giving birth, going through menopause at an older age, short menstrual cycles, heavy menstrual periods, having higher level of estrogen in the body, low body mass index, one or the more relatives of endometriosis, or sister, aunt, mother, someone is suffering.
उनको join करा ले, पूछ ले.
So impact is social, public health, and economic implications. It can decrease quality of life due to severe pain, fatigue, depression, anxiety, infertility. And these are all the impact on the life of a woman who suffers from this disease. And diagnosis obviously is through now the modern technologies are available, MRIs are there, scans are there, which can be done to rule out that this disease is there or not. Then these are the manageable, which doctors generally do. Now we come to the support therapy, that management through nutrition, how we do it. So nutrition and endometriosis, where as a nutritionist I receive very less cases of endometriosis, Now only when woman is infertile, then they are asked to lose weight, and then women come to us. Nobody is coming to a nutritionist for the management of endometriosis, because people don't know that nutrition has a role. They think the diabetes or obesity is only controlled through nutrition. So this is a sad part at first, and it is we know that it is an inflammatory condition. So first of all, what we say that anti-inflammatory diet can be useful for the endometriosis, because managing the conditions involves and as we have discussed, that it will impact your environment, this disease. So anxiety, depression, or mood swings, or general things can be improved through the nutrition. I am not saying the total symptoms will go away, but I'll say that the pain would be naturally reduced if the nutrition is proper and you are taking certain form of nutrients in the diet. So this will improve the quality of life. So nutrition plays a significant role in managing this disease by potentially reducing the inflammation, balancing the hormone levels. So this has to be noted that the hormones are not to be only controlled through medications, but nutrition plays a major role, and providing essential nutrients that help alleviate pain, as like we say our neurotransmitters are the pain alleviators, and the pain can be reduced a lot by using this. So link between pro-inflammatory diet and increased endometriosis risk, making an anti-inflammatory diet with high fiber, antioxidants, certain vitamins like vitamin D are potentially beneficial for those with the condition. However, further studies are needed to fully understand its impact. But there are many studies which I will cite also, that who supports that this disease can be managed through diet or nutrition. Then dietary fat is first thing that we'll discuss today. So there is in 2010 a study found that intake of palmitic acid, that is a saturated fatty acids, which is derived from mainly meat and dairy products, and trans fats, was associated with increased risk of endometriosis, while total fat consumption did not confer the same risk. So the quality of fat impacts a lot what you are eating in your diet, not only the unsaturated, but whether the fat quality. So as we say protein quality, there is a quality of fat as well. So please avoid the trans fats are in all processed foods that we are eating day to day life, like in biscuits, in even candy, even cake pieces or muffins or any bakery products, all have the trans fats that are used in the industry. Or if we are not eating the natural butter but the margarine, so that also comes into this category. So these increases the risk of endometriosis. So one of the cause we can remove through our diet. Then animal fats are of particular interest, as high consumption can be linked to other gynecological diseases also. So NIH AARP Diet and Health Study found that this is the participants with the highest total fat intake had 28% risk for ovarian cancer as compared to the lowest intake. So again, the fat becomes the villain, but not all fats are bad for the body. In contrast, certain fats may play protective roles. So in 2010, again, one study proved that 70,000 premenopausal women reported that consuming most omega-3 fatty acids are likely to be diagnosed with were less likely to be diagnosed with endometriosis. So compared with lowest omega-3 consumption. In a human diet, it is the sad part that we are consuming mostly the omega-6 fatty acids, not the omega-3. And if there's one question that always arises, that omega-3 is in the non-vegetarian food only, like fish oils and all. But it is not true. If you are having flax seeds diet in your diet, it is very rich in omega-3. Broccoli is rich in omega-3. So if you include these in your diet, you can get omega-3 from natural sources. And always there is a ratio of omega-3 and 6 in your body. The more omega-6 fat you are having in your body, the less omega-3 fatty acid is absorbed. This is one of the major problems. So obviously, the omega-6 fatty acids are in soybean oils or the oils that we consume, refined oils that we consume daily. So they are all omega-6. So we have to we have to maintain a ratio that omega-3 fatty acids are also going in your body. So this will be also one of the factor that will support the women body. Because estrogens are likely a key pathogenesis of endometriosis, dietary factors that modulate estrogen activity may be clinically important. Reducing dietary fat, increasing dietary fiber is shown to reduce the circulation of the estrogens roughly to 10 to 20%. The same phenomena has been identified in post-menopausal women. Some have suggested that estrogens occurring in animal products, particularly dairy and meat products, they have biological impacts when ingested. And some studies also have supported the intake of lactose-free diet. So if we have lactose less in our diet, then also we can support such patients because of the hormonal problems. Then comes the meat intake. Two prospective studies also shows this, that more than 2 servings of meat per day had a 56% greater risk of endometriosis as compared to those who have 1 serving of red meat per week. Increased poultry intake was also associated with higher risk of endometriosis. So this is also one of the things that increased risk associated with fish, shellfish intake was no longer apparent after adjustment to the race. So it depends on the racial or races also. So studies, please do not follow blindly the studies that is published over the internet. Always seek it to what population the study has been done. If a study is being done in India, then only it can be beneficial to our race. If this study is done in the China, the race is completely different. If it is done in US, because of the genetics, because of the gene expression, the whole intake of the food is being changed. So if wheat is my staple diet, so it is not necessary the person who is living in the other part of the world, the wheat will be very much suited to them. It is not so. If rice is staple diet of Japan, or noodles can be eaten by them and it will suit us, that is not the case. So we have to see where the study was being done and how it will impact. So it is very important where the population is belonging, the study we are citing. So this study is done but not applicable to all. But again, there are certain general studies which are done on the nutrients like omega-3, omega-6. So that is being applicable to most of the cases. In an Italian study reported, like in Italy it was done, the increased odds of developing endometriosis associated with high intake of beef, other red meat and ham. Red meat consumption may be associated with higher levels of estradiol, estrone sulfate, and thereby higher concentrations of steroids, inflammation, and development of this disease. So again, but I must say that red meat has a lot of researches which oppose red meat for the human body. And if the consumption is more, then obviously inflammation increases, and not only endometriosis, it can lead to obesity, it can lead to pancreas destruction, it can lead to liver problems, it can lead to kidney problems as well. So to control inflammation is one thing that is important through diet. Then there are biological role of in endometriosis. So we have given the tried to give in a easy manner, like red meat and unprocessed food associated with increased risk of, not food, this is meat, with the risk of endometriosis. Red meat processed associate with increased risk. Dairy products again increased risk. Dietary fat, and it is increasing in the estrogen concentrations. Then dietary fiber, seaweed, polyphenols, vitamin D, C, and E. So these are all anti-inflammatory, so can be taken in the diet, because the diet has never no side effect is there. But do not take any herbal supplements which are claiming that ginseng le lijiye, you can have ashwagandha for the fertility issues. We do not support such supplements because until and unless it is prescribed by a qualified doctor. Do not take them by by yourself, that this supplement is good, so we will take this. Like I have written seaweed, so it is also to be taken under prescription, because there are certain amounts that are being prescribed, and do not exceed that amount. That will have negative impact on the body. So fruits, vegetables, calcium, vitamins, dairy products, fish oils, polyunsaturated fatty acids lower the risk of endometriosis. Then role of inflammation is very much in the endometriosis. So the fact that reducing dietary fat and increasing dietary fiber will reduce the circulating estrogen concentration, the effect of plant-based diets. So there is another type of diet. One is, I have told you, anti-inflammatory. The second type is the plant-based diet. The plant-based diet especially concentrates on the lactose-free diet, that you have to omit all the dairy from your diet. That vegan diet only supports that you have to take only the vegetables, fruits can be eaten, gluten can be eaten, but not the dairy products. So strictly vegan diet has shown that it has anti-inflammatory properties. This is one kind of anti-inflammatory diet. But there is another kind of anti-inflammatory diet in which we restrict gluten, means we stop the wheat intake so that the inflammation is stopped. So it depends how aggravated are the symptoms. If the symptoms are too much aggravated, then we have to stop certain amounts of food products. Then there is another study which supports low-fat vegan diet was shown to increase plasma concentrations of sex hormone binding globulin, which in turn would be expected to reduce the estrogen activity. The diet also reduced the severity and duration of pain and moderated premenstrual symptoms. So this is another study. Then another study showed that low glycemic index foods are associated with the reduced risk of endometriosis. So in the beginning only, I told you that the bakery products, which are rich in trans fats, every trans fat food, rich product may be sugary. It can be a sugary product. So these also increases the risk of endometriosis. So sugar is another villain that causes the inflammation in the body. Then plant-based foods contains a decreased amount of polyphenols, which when compared to omnivorous diet, which when metabolized into bioactive compounds can reduce inflammation. When comparing a plant-based diet to an omnivorous diet, the gut microbiome contains larger number of anti-inflammatory compounds. So this is also low-fat plant-based vegan diet is also being supported in this disease. Or you can say the hormonal disorders are managed through, support therapy is given through this anti-inflammatory low fat, no trans fat, omega-3 rich, high fiber diet, or a completely lactose free diet, what we call vegan diet, can be adopted. And if a person is having the gut issues also associated with these diseases, because what happens whenever the body is in tension or body is in stress, so obviously gut is the second brain, it will also be disturbed. So we have to see whether we have to restrict the gluten.
Yeah, come.
Then free radicals.
I'm in a It's okay. What did you have?
So free radicals are generated through physiological processes, and these are the another problem that can be caused due to these. So antioxidants are only the answers for this, and there are certain kinds of antioxidants that are present in certain foods and certain tablets. So antioxidants can be prescribed through doctors also, because it is in the depend on the researches that what kind of antioxidant is beneficial for endometriosis. So that is supplemented vitamins, because vitamins and minerals are also a kind of antioxidants. So, and also the vitamin C, 30% if the women had the lower intake of vitamin C and consume 40% of less vitamin E. They then compared with the women who did not have endometriosis. So this study showed that high antioxidant diet for women with endometriosis displayed high peripheral concentrations of supplemented vitamins. So again, the supplementation has to be controlled, and also obviously the symptoms are reduced, but toxicity of everything is bad or excess of everything is bad. This is also being proven in many studies. So जैसे कि if the water is good for health but do not overdo it, do not take the 4 liters of water per day. Only 2 liters is sufficient for human body. So don't overload your kidneys and liver with popping the pills of supplementation that it is good for health. Try to take natural food products, because liver does not have any burden of the metabolizing the nutrients, but it has a burden of metabolizing the medications, whether it is in the form of the supplementation. Then macronutrients and protein sources. This is another part, that protein is very much less in the Indian diet. So because we are mostly vegetarians, so if you calculate your protein, that will not come equal to the 1 gram per kg body weight. So that is, the ICMR has now decreased that a 60 kg of man or woman has to take 40 grams of protein per day, because even we are not able to complete that. So there are certain food products and proteins also that we restrict for if there are hormonal issues, like soy products are one of them. Otherwise, salmon, tuna, mackerel, everything can be given because they have the anti-inflammatory properties. But we cannot really say that you have ample amount of pulses in the diet, because it has a urea product that deposited in the body, so you can have high uric acid levels. So in the absence of dairy, so we have very less if a person is not non-vegetarian, so we have very less options for the proteins available. So you can have quinoa, it has very good impact. You can have another millet forms that can be given to the vegetarian people. And additionally, walnuts, flax seeds, chia seeds, canola oil are excellent sources of unsaturated fats that can contribute to hormonal balance. Then comes the vitamin B6, that is also very important for balancing estrogen and progesterone levels. So foods rich are poultry, avocados, peas, pumpkin seeds, that can be taken into diet. Magnesium is also very important for hormonal balance and symptoms associated with endometriosis. Leafy greens such as spinach and kale, legumes, nuts, but don't take overdo. Follow the food pyramid. It is the basic chart that tells you how much is to be taken per day. Like 6 to 11 servings of cereals are to be taken per day, not more than that. This is written in the food pyramid. Beta carotene, that is found in oranges and green vegetables, carrots, sweet potatoes, spinach, that is precursor to vitamin A, and it boosts the immunity and fertility. Then comes the minerals. We have discussed the vitamins, fat, proteins, carbs. Now comes the calcium, potassium, magnesium. These are all minerals. So calcium is important for bone health and also the muscle functions. So it is also, calcium is important for mitigating muscle cramps, pelvic pain associated with endometriosis. Magnesium, we have already discussed. It supports the nerve function and help in reduces headaches, improving sleeps and concerns over associated endometriosis. Phosphorus is also important because calcium and phosphorus are in 1:1. So एक decrease होगा, so दूसरा भी it will go down. Similar cases with the sodium and potassium, again 1:1. So we have to balance the sodium electrolyte balance in our body. So it is a key. So do not have low salt diets unnecessarily if it is recommended. So people are having this Sendha namak nowadays. Iodine is also being absent in the diet, so it is contributing to the thyroid disorders. Then sulfur involved in detoxification processes of the liver, so tissue repair is one of the function. And chloride is again very important for the body. So do not omit or do not take low sodium salts. Then anti-inflammatory fruits are, we have already discussed about it, but the many researches show that omega-3 fatty acids have combat the inflammation and help alleviate pelvic pain associated with the endometriosis. So food can be very helpful for such patients. So foods to avoid are certain foods are advised to be limited or avoided. Processed and refined foods, especially those containing trans fats, artificial additives, and sugars, and can exacerbate inflammation or should be minimized. Red meat and processed meats have been linked to worsening the symptoms of endometriosis. So no क्या है जो avoid करने हैं, that is alcohol, caffeine, fatty meat, sugary drinks and processed foods. Low GI foods hai, that is now the sugar has to be less in every food. So don't, if you have to prefer cornflakes over muesli, so you have to prefer muesli because cornflakes are also considered to be high in starch. And people are mistaking corn as a healthy food, but corn is not because it is a high glycemic index food. So corn should not be eaten. Sweetened corn to bilkul bhi nahi lena hai because it is considered to be healthy, but it is not. Fiber intake has to be increased 30 grams of fiber per day because so that the gut health is maintained and also reduces the inflammation and symptoms of endometriosis. Eat smaller frequencies, don't have 3 large meals, instead have small feedings at 5 to 6 times a day. And adequate hydration is important because it will also balance the water electrolyte balances in the body. Then omega-3 fatty acid and iron may provide additional support to women with endometriosis. Iron-rich foods, dark leafy greens, eggs, fish are recommended, particularly for those who may experience heavy menstrual bleeding. So this is the summary that we have to fight the inflammation that is caused by the endometriosis, and hormones have to be balanced for the women who suffer from this. So then the mental health is also comes into the picture of such women because foods will soothe that. The neurotransmitters also function as the pain relievers in such conditions. So food can be one thing that can relieve the symptom of the disease. And fibrous foods, iron-rich foods, essential fatty acids. So have a healthy food, and please don't jump on the salads. Raw food materials also causes bloating. So if you are having a lot of salad, so don't do that. High fiber diet doesn't mean that you have to eat bowls of salad. You can blanch the salad, then you can eat it. And there are certain myths associated with the diet, so don't go for that. Don't listen to everybody. And one thing is like low carbohydrate diets. The carbohydrates are also very important part of our diet. So do not go for low carbs, no carbs, or low fat or no fat diets because every nutrient has a role in the body because nutrient works as a family together. So because our metabolism of the nutrients in the liver is incomplete if a slightest of the micronutrient is absent. So this was the my lecture about the endometriosis and nutrition. And sorry for my bad throat. I am not well today, but I hope I am able to deliver what is being expected. So thank you so much. Thank you for listening patiently. Thank you. If any questions, you can proceed, please.
So thank you so much, Dr. Lakshita. It was a very informative. Yes, we do neglect diet most of the times, but yes, anti-inflammatory, vegan, and antioxidant diet does play a very important role. And I can see you are having such a you have explained everything in very detailed. So thank you so much. So if any questions are there, we can have or at the end of the session. Okay. So, Dr. Shweta, I would like to call Dr. Shweta Mittal, ma'am. Ma'am is.
Ma'am has, I think, logged out. Let's start the second session talk.
Okay. Okay. So for second talk, I would like to call Dr. K.D. Nair, sir, to introduce Dr. Shweta Gupta, ma'am.
Again, good evening, everybody. हाँ जी बेटू कर रहा हूँ मैं.
हाँ जी, हाँ जी.
We invite Dr. Shweta Gupta. She is the director IVF at Max Super Specialty Hospital and director of SG Clinic in Noida. She is RCOG North India Fellow Representative, and she is the team leader of Delhi IFS Forum, which has been created in this term. She is also convener of SIG Endometriosis from our society, and she was editor of Indian Fertility Society 22 to 24, joint editor 20 to 22, and she is an international examiner for RCOG, and she has won a lot of awards. Welcome, Dr. Shweta. We got to listen to you, what you're going to talk about.
Thank you, sir. Thank you very much. So I'm going to speak today on ovum preservation, especially for the difficult cases of endometriosis. So what are the nowadays options, how we can deal with uh, severe endometriosis and the latest trend in egg freezing. So endometriosis, we all know, is a chronic inflammatory gynecological condition and is seen in about 32, in fact, up to 50% of infertile women. And oocyte cryopreservation is an option for fertility preservation, which I'm going to discuss in detail today. We all know that endometriosis has a damaging effect to the ovarian reserve. There are different types of endometriosis. The superficial pelvic endometriosis, which is found in 15 to 50% of women, and there are different lesions, different type of lesions like red, black, or white on laparoscopically, and which represent the progression of the disease from vascularized active lesions to advanced disease to its quiescent phase. And these presence of ectopic lesions on the peritoneum reduces the chances of spontaneous fertilization threefold. We often seen endometrioma, which may be in some studies seen up to 44% of women, and their presence significantly lowers serum AMH. AMH is a test which checks the reserve, ovarian reserve, and it is seen when endometrioma, it severely reduces the AMH also, and especially if there are presence of large ovarian cyst or endometrioma and bilateral lesions. There is noted to be a faster decline in serum AMH levels compared to their age-matched counterparts. And these features are attributable to several complex interacting factors, including increased primordial follicle activation that give endometrioma this inherent characteristic of increased ovarian aging. So endometriomas are expected to cause a significant damage to ovarian reserve and function. And these cysts, even before surgery, they have a toxic content that can lead to unfavorable effects such as increased oxidative stress, increased fibrosis, loss of cortical specific stroma, and smooth muscle cell metaplasia. Some oxidative stress components, such as iron derivatives, can easily diffuse through the endometrioma wall. Ovarian cystectomy has an irreversible damaging impact. The risk of causing definite injury to the ovary with the classical technique of laparoscopic ovarian stripping is seen in 10 to 15% of cases. And women operated on an ovarian endometrioma showed a reduction in AMH level of 1.54. Ovarian response to stimulation is also lowered in operated gonads. Iatrogenic infertility, we have often seen that the patients, they go for cyst, they get laparoscopic surgery done, and excision of bigger chunk of ovarian tissue with the endometrioma leads to decrease in ovarian reserve and AMH levels. And second surgery for endometriomas has a notable negative impact on ovarian reserve. So bilateral laparoscopic surgery for endometriosis leads to a more significant reduction in AMH levels compared to unilateral laparoscopic surgery for endometriosis. And women who undergo surgery for bilateral endometriomas experience menopause at an early age and have a higher likelihood of post-surgical premature ovarian failure. So whenever possible, one should be careful about operating too much on ovaries. Ovarian surgery is not always necessary, and preventing surgery is the first step in protecting the ovaries. If surgery is needed, keep it minimally invasive removal of a cyst, which we call cystectomy. No matter the complicated nature of the surgery, the goal is that fewer ovaries are removed unnecessarily and improving the lives and reproductive outcomes in young women. So there is this study where for patients considering surgery, the risk of iatrogenic surgery is among the most important factors in the context of fertility preservation, along with age and individual reproductive goals. In case of endometrioma, excision overwhelming demonstrates the negative impact of surgery on ovarian reserve with significant reduction in AMH. So up to 30% in unilateral versus up to 44% in bilateral endometriomas. So there should be good counseling regarding fertility preservation. Any surgical endometriosis patient should undergo a thorough counseling, and there should be discussion about the tissue embryo oocyte cryopreservation options. And when performing surgical interventions for endometriosis, reproductive surgeons should employ fertility conserving surgical methods to reduce the likelihood of post-operative iatrogenic diminished ovarian reserve. Recurrence. Even if you do very good surgery, this disease is known to recur, and the disease has shown to recur in 22% of women at 2 years, and almost half of the patients they have recurrence of endometriosis in 5 years. So roughly about 10% rate per year. So all types of endometriotic lesions have a high rate of recurrence after conservative surgery, and it is a substantial problem in the clinical treatment of endometriosis. So when we look into egg freezing or ovum freezing, we need to give a very personalized fertility counseling where we took into different aspects. What is the age of the patient? What is the extent of ovarian involvement? What is the current ovarian reserve? What previous and impending surgeries are planned for endometriosis? And then along with the current success rate and possible risk associated with fertility preservation techniques. So we in this chart we can see we have to ask a patient whether she desire fertility or desire immediate fertility or future fertility. Then we do the ovarian reserve testing by AMH and scanning, and those who require immediately they should undergo or fast track her fertility treatment. Those who are considering ovarian reserve testing and in future they need, then we have to categorize as per their age and the ovarian reserve testing result. ASRM had announced egg freezing as a standard treatment now. It was earlier experimental, but since 2013, it has become a standard, and very much nowadays it is done in most of the IVF centers. And we usually do the vitrification. It has shown to reduce the risk of ice crystal formation during freezing. So we also, along with the egg freezing, we have embryo freezing and ovarian tissue cryopreservation. Now, though there is no clear-cut consensus that which patients in endometriosis should be counseled, but it is advisable that patients who have large or bilateral endometriomas and previous ovarian surgery, this should be advised. The success rate of oocyte cryopreservation may vary depending upon the age, ovarian reserve, and surgical history. Embryo cryopreservation requires the male gamete and has ethical and legal implications for death or separation. Ovarian tissue cryopreservation is a valuable option for patients who cannot undergo controlled ovarian stimulation for urgent surgery. So there are different studies, and this study by Elizur et al. They said that women who underwent endometrioma surgery before had a 51.7 reduction in the number of M2 oocytes compared with women with endometrioma who did not undergo surgery. And there are guidelines issued by ESHRE that they said that when you do the egg freezing and you do the stimulation, there is no clear-cut protocol. Specific protocol for ART in women with endometriosis cannot be recommended. So you can use both antagonist and agonist. And also the women with endometriosis can be reassured regarding the safety of ART since the recurrence rates are not increased compared to those women not undergoing ART. If you puncture endometrioma, then use antibiotic prophylaxis at the time of egg retrieval. The extended administration of GnRH agonist prior to ART treatment to improve live birth rate in infertility patients with endometrioma is not recommended. So the earlier what we used to say the extended GnRH agonist, now that is not recommended. And I think we will just take few important ones, that the surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or accessibility of follicles. Otherwise, they are not recommended for routine ART. So anyone who is having ART, they need not get operation done, that is ovarian endometrioma excision, only if there is a pain or if there is a problem in accessibility of follicles. So how many numbers are good for freezing to have a decent number, a decent good number for a single child? So they have made this table, which is according to the age of the patient. If she is a younger age patient, then the less number of eggs and maybe one cycle is sufficient to give a realistic chance of a child. But if the age is more, then she may have to undergo 2 or 3 cycles of IVF stimulation to have a decent number of eggs. And this is a famous study by Kobo et al. That a woman, if she is a younger, then she has a better percentage of cumulative live birth rate, which is 60.5%, and less number of eggs are required. But if the woman is more age, more than 35, then the cumulative live birth is 29% with 10 oocytes, half the rate obtained in the younger group. Now, there are different studies where they have said the question comes where if we are freezing eggs, are they good enough as good as fresh? Yes, there are a lot of studies which have said that they have a almost equal number of pregnancy rate. So there is evidence which is based on RCT and meta-analysis that suggests that pregnancy rates after IVF or HC with vitrified oocytes are similar to that for the fresh oocytes. And there is no increase in chromosomal abnormalities, congenital anomalies, or developmental delay in offsprings from pregnancies resulting from cryopreserved oocytes versus the general population. Now I'll just briefly touch about the ovarian tissue cryopreservation. That means not taking out eggs, but freezing the complete ovarian tissue. Now this was experimental, but in 2020, ASRM removed the experimental label from ovarian tissue cryopreservation. It requires 2 surgical procedures. First is to harvest the ovarian tissue, and the second is for transplantation. What we do is the ovarian cortex surrounding ovarian cyst can be considered as a source of ovarian tissue for cryopreservation procedure. And it involves a surgical removal of ovarian tissue followed by freezing of cortical tissue prepared a thickness of 1 mm. And in the beginning, the cortical tissue is processed for freezing that requires cryoprotectants to avoid damage to the cell integrity. And then the tissue is then stored in a liquid nitrogen until the tissue is ready to be transplanted. So as you can see, this is a small tissue, ovarian tissue, and then it is prepared into cut into smaller pieces, and then it is combined with cryoprotectants and it is frozen into the liquid nitrogen. So the advantages are that it provides a future fertility and also hormone production in children and adults undergoing treatment for cancer or other diseases that affects the ovaries. And in about 30% of people with formerly frozen ovarian tissue who had the thawed tissue reintroduced into the pelvis were able to give birth. So, not going very much in detail about ovarian tissue, but then it is done through the laparoscopy, and one ovary is removed, and then it is cut into smaller pieces. It is frozen, but then if you have to put it back, another laparoscopic surgery is required, and there are different ways of putting back, whether we can put back into the same place or whether it can be put into the far off place. Oh, whole ovary. There is also a concept of whole ovary, but the cryopreservation of whole ovary followed by vascular anastomosis of ovarian pedicle has been suggested to decrease ischemic injury and provide a suitable follicular reserve as well as longer lifespan of the transplant. But it is very technically challenging as there are different tissues of different composition and different size, so not routinely done. So as putting back the thought, it can be done in the same place, that is in the ovarian fossa, that is called orthoptide sites, or it can be put at a distance from the ovary, subcutaneous tissue in the arms, so that is called heterotopic sites. And follicular growth has been observed at both the sites, but almost most of the pregnancies, almost all pregnancies and live birth have been reported at an orthotopic site, which is behind the ovarian fossa, and it continues to be the first choice when applicable. Now, specifically for endometriosis, this is a study by Carillo et al., where the in cases of endometriosis, they've done the ovarian tissue cryopreservation, and they found good results. So healthy ovarian cortex fragments might be isolated and cryopreserved during the surgical removal of endometrioma. So conclusion is that it is very important that we should ensure there is enough awareness and availability of counseling for ovarian and oocyte and ovarian tissue cryopreservation, especially in cases who have bad endometriomas. They undergo repeated surgeries, they suffer from pain, and ultimately in the end they are left with no ovarian tissue, and it really becomes a problematic for IVF consultant to give them a baby of their own genetic material. So but very important that we not only give the awareness, but also good screening and a very good counseling with the realistic long-term reproductive plans, and timely referral is important. The good practice point is that oocyte cryopreservation is an effective method for fertility preservation in women with endometriosis. Success rate depends upon the age, ovarian tissue, and surgical history. And embryo cryopreservation is also there for those who are already married or those who have a partner. Ovarian tissue cryopreservation, it requires a laparoscopy. Potentially associated complications like removal of ovarian tissue causes damage to ovarian reserve and may promote the development of post-operative adhesions. So the problems of laparoscopy are also there, but this is one option which can be done. Thank you.
Thank you so much, Shweta ma'am. We are grateful for your valuable and so informative session. I know most of us will be applying all your points in our daily practices. So, any questions anyone have, or we can take it later on also. Okay, so I would like to invite Dr. Soumya to start the second session, and please call the experts.
Thank you, Dr. Sabina, ma'am. So we have just explored the clinical aspect of endometriosis, from diagnosis, treatment, its challenges. But managing endometriosis isn't just about medical and the dietary treatment. Its emotional and psychological support plays a very crucial role. So the next session is about counseling the patients of endometriosis. So for that, I would like to call the experts. Rahul, please display the slides for the experts for the next session. Is Dr. Amita ma'am here? So I would like to call Dr. Amita Puri ma'am. She's Director, Optimus Center for Wellbeing, Triumph Foundation also. She's gold medalist with PhD from PGI Chandigarh on a fellowship MPhil clinical hypotherapist, worked as a faculty at IIT Delhi. She's a regular presence in prominent media platforms, including various TV channels, newspapers like Dainik Jagran, National Herald, Hindustan Times, and FM radio. Next slide, please. I would like to invite Dr. Sumati Bachchan, founder of Vadhu Life, counseling psychologist, clinical hypotherapist, NLP master practitioner, and life coach. Ma'am, I would request you to please invite our first speaker for counseling session, Dr. Poonam ma'am. Slide for Poonam ma'am.
Yeah, good evening, everyone. I would like to introduce our next speaker, Dr. Poonam Nair. She's into teaching and research in psychology. She integrates yoga-based mind and body methods in psychological disorders and IVF treatment. Chairperson for the 2024 IFS Clinical Consensus Guideline for Psychosocial Care and Assisted Reproductive Technology. She is a member of Scientific Review Committee for International Journal of Yoga Research and executive member of the Indian Fertility Society. So over to Dr. Poonam Nair. Poonam ma'am.
Yeah, I want to share the screen. It's saying only presenter. Okay. I'll be talking about counseling for endometriosis, and it's been a challenging process to explore and find things for the work for it the best way forward, because endometriosis and psychological counseling, how they link together, that was the uh, a very interesting journey for me personally. I'll just share the screen somewhere. 1 minute. Just let me exit and open my PowerPoint. 1 moment, please. Mhm. Okay. So, can you see my screen now? Okay. Yeah. Mm. Okay. So I was trying to work through this uh, whole paradigm of how to give best counseling approach for endometriosis. And here you can see definitely it's not the counselors working here, it's the surgeons. So it's a new area, and I think not well explored.
Ma'am, could you please put it on slideshow? It will be better visible then.
Yeah. Okay. Is this better now?
Yes, ma'am. Thank you.
Okay. So these are the symptoms already well talked about, so I won't be repeating that. But the core symptom that is of a lot of significance for managing is the chronic pain which is there in endometriosis. And having a chronic pain, it's very uh, disturbing. It's very difficult to work through life when one is carrying this pain all the time. Now, why does the pain become so chronic? One is the diagnosis of endometriosis is delayed, and because when women experience menstrual pain and lower abdominal pain, there is little possibility of confirming the diagnosis, and the changes in the organs are not visible in the initial stages. So invasive diagnostic procedures is not the first choice. Women with menstrual pain do not undergo laparoscopy right away. So there's when they come with menstrual pain, what is the guideline? Is it normal? Is it going on the high risk area? I assume you're all very good clinicians, so you'll be able to judge. But as such, I could not find if there is a well-defined criteria for looking at it more seriously. Generally, the women find that it is dismissed as normal, and there is an attitude that women exaggerate or imagine their symptoms. They have low pain threshold, and they are told that their menstrual pain is normal. So this is the thing, that they go into a mode of denying their own pain. Now, because of this delayed diagnosis, again, it seems that they have been complaining for almost for 10 years. And in more than 60% cases, the symptoms occurred before the age of 20. And they had visited up to 10 different physicians before the diagnosis was finally made. Until then, they received inadequate and inconsistent therapies. So pain becomes a major cause of psychological distress. There is pelvic pain ranging from mild to severe, progressing on cramping, stabbing pain occurring on both sides of pelvis, lower back, abdomen, rectal area, and even down the legs. And then dysmenorrhea, dyspareunia, that is painful sexual intercourse, dysuria, urinary urgency, frequency, and painful voiding. Then pain associated with ovulation and body movement pain, the pelvic floor muscles go into spasms. And women with deep endometriosis are likely to report shooting rectal pain and a sense of their insides being pulled out. So this is the if you have to see that it affects immediately their personal intimate life, there can be problems in the relationship. And what are we actually looking at? Is this, what kind of pain is this? We are taught in biology that there is a nociceptive pain which is essential for the body's survival, because it tells you, the organism, that there is danger, and the tissue, the all the response has to be mobilized to protect. So this, to that extent, it is a biological signal. That is, there's bleeding of endometriosis lesions during menstruation, accumulated blood, immune response, circulatory and lymphatics, leading to swelling and inflammation, pain, and organ dislocation from adhesion binding internal organs together. So internally, there is obviously a lot of hurt going on. But is all the pain having nociceptive origin? Because nociceptive pain is not to be not to be stopped. Otherwise, the body loses the sense of self repair. Here, but the interesting thing is that the amount of pain a person feels correlates weakly with the extent or the stage of endometriosis. The individual pain areas and the pain intensity appear to be unrelated to the surgical diagnosis, the area of pain unrelated to the area of endometriosis. So some women experience little or no pain despite having extensive endometriosis or endometriosis with scarring. Others have severe pain even though they have only a few small areas of endometriosis. So here the question of diagnosing, identifying, what is actually happening. So the concept is now of nociplastic pain, developed by the International Association of Study of Pain, that this whole pain, it is actually the neuroplasticity which has gone wrong, in the sense that there is what is called central nervous system sensitization, where there is an amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. So what was to be a protective mechanism has become now, which is now amplifying the pain signals. Then also there is what is called neuroangiogenesis, that the endometrial lesions develop their own nerve supply and blood vessels. So they create a direct two-way interaction between the lesion and the central nervous system, producing individual differences in pain perception. And then there is hyperalgesia, that is peripheral sensitization of local nociceptors, which increase the responsiveness at the primary site of pain. So besides the typical tissue damage, pain signal, there a lot of other factors start coming into play, and these are very important for counselor to know, to be aware of, so that they can navigate the patient through the pain, and like they learned the pain, they can unlearn it as well. So there is this changes in the cortical function, where chronic pain actually changes the brain structures, and there is a lowered pain threshold at the central level. So initially we started here with nociceptive or protective pain, but repetitive, slowly expanding, and then due to upregulation and downregulation, there was actually what is called the central nervous system became hypersensitive to pain. It started facilitating the nociceptive pain, which was entering into the awareness through the brain. So there is a whole program of what is called patient neuroscience education, where as a very first step of uh, managing the person is to explain them the neuroscience of pain. And there are modules developed for it. I'll share some of them with you. So basically, the idea is that you demystify the biological and psychological aspect of pain. And because they start to understand, they can manage their condition more effectively and develop a sense of control, which is crucial for pain reduction. It motivates them to become active participants in their management program. And most important, it helps the patient to understand that pain doesn't reflect health of their tissue. Otherwise, when there is chronic pain, then a lot of rumination starts about why it's happening, what maybe it's this or maybe it's that. So this kind of understanding clears their thinking, and it helps to change their maladaptive thoughts about pain, such as catastrophizing. So this is a simple part from the patient education module, where they explain to the patient something like this. So what happens when a camera strobe flashes? For a moment, there's a flash, blinding flash in the eye. And after that, continue to see a blue dot. So is the blue dot you see after a flash real, or is it just in your head? Is it real? Or it is real? We see it. We can't say it's not there, but it's not there also. So there is no blue blip in the room, but the sensory after image is real sensory phenomena. So this is sensory after image is the product of hyperactive nerves created by sensory system overload. And chronic pain resembles a sensory after image in many respects, where when pain and stress overload creates hyperactive nerve. So some amount of sensitivity is going to be there because of the tissue process of endometriosis, but the study has shown that there is no correlation with the level of pain, or weak correlation. And if they can manage their pain, they can still continue to have a functional life. So this optical after image can persist after the light has gone. So here the same chronic pain is a type of sensory disorder which can persist even after the illness or injury is gone. Like in endometriosis, the injury is there, but the overstimulation, hyperstimulation magnifies, amplifies the experience of pain. So recent research suggests that chronic pain is a disease state that is distinct from the illness or injury that started it. And so we can explain to the patient that like an onion, chronic pain has many layers. There is starting with, we start here, and then there can be neuropathic pain due to nerve injury or dysfunction. Then we get stress related muscle tension and spasms, which add to the pain. And then we get insomnia and exhaustion, increased pain and reduced pain tolerance. And then we get frustration, worries, depression, negative thoughts. and that add to our suffering. So here the things that can be controlled in counseling, in patient care, can be at least some of them, if not the entire lot. So here I'll just talk about the pain sensory system a little bit, that we are now not only talking about the pain coming from the endometrial tissue, but it's affecting the level of arousal. The person can't sleep. We are talking about the muscle tension this is talking about the reticular activating system. Then we are talking about emotions which are activating the limbic system, the weak immune response due to stress. Then sensation and movement is when there is pain. People think, okay, if we rest, stop, we get immobilized, we'll recover. So this is a self-protective behavior which gets triggered. And then we have pain cognitions coming from the frontal cortex. So pain is no more now here at the endometrium. It has gone right into the central nervous system, the experience of pain. And then we have the reaction like we try to cope up with the world. Will I get better? Then you start getting memories of the pain because it's been going on for so long. So there is this whole system, a pain center, which becomes a central sensitization mechanism, where the entire brain gets activated. Now here, so when does the chronic pain begin? When actually the central nervous system, because it's very neuroplastic, so continuous bombarding with pain, it remodels itself so that chronic pain becomes less closely associated with sensation, more closely associated with arousal, emotion, memory, and belief. It can happen quickly or not at all. So this is where the counselors need to explain to the patient also what's happening so that they can have a logical and an effective treatment plan. So now we shift to the biopsychosocial model of pain, which integrates biological, psychological, and social factors to manage this pain, which is a very big hallmark of endometriosis. And where we are talking now about nociceptive pain, which is we are all aware of, defensive, healthy mechanism, to what is called nociplastic pain, where the brain has got adapted due to down regulation and up regulation of nerve impulses. And this is what the counselor can focus on. This is the hormonal treatment and the surgery. Then when you go on to pelvic floor exercises, physical exercises to release stress, pain management techniques, and psychotherapy. So has to be a balance for outcome. And there was a very beautiful study where they mandated that this integrated approach should be there for pain management. And the outcome was like they saved so much money in terms of relapse, recurrence, and patient satisfaction and the quality of life. So here, the first step is to assess the pain for the counselor. So there are questionnaires for it, where we look at the pain intensity, distribution, we look at variability over time, whether then we have to explore the beliefs about the condition of the patient. Are they hypochondriac? Are they in denial? What are they doing about it? And then stress related symptoms, depression and reaction, anxiety, anger, trauma, and so on. So here, finally, we have to, the person has to live in the world. How are they coping in the world? So these are the dimensions which have to be picked up by the counselor so that they can have a well-directed therapeutic approach depending on which factor is playing up. And then coping with the world, what is their support level? How is the family supporting? How is the workplace? How is their work affected? And so on. So all those aspects, when they are there, we can then, uh, look at uh, this this entire thing has to be done. So before we can talk about pain management and putting the person into counseling process. Why isn't my it's stuck? My presentation is stuck. एक minute. Okay. So this is central sensitization, which we were talking about, where the emotion is, I hate my pain, muscle tension is this, I need a massage, arousal, I can't sleep. Because central sensitization means weakened descending inhibition and magnifying ascending signals. So the memories of pain. So all this thinking, worrying, what's happening, how will I do all this? So all this makes the central nervous system liable. So we have various counseling approaches, individual counseling, group counseling, CBT, mindful based therapies, and we have relaxation training, behavioral sleep treatments, which affect the lower brain centers to help bring down the activity. We have biofeedback also. For the same, it works at the RAS, the arousal centers of the brain. Then affective therapies, which deal directly with the emotional, the reaction, this is horrible, this is too much, pain is different from suffering, and the emotional reaction to this experience. Hypnosis and imagery is very useful in such conditions. Then solving life problems related to pain, that is how they can make adjustments with the work and so on. And the cognitive therapy, pain education is the fundamental starting point, which we have already talked about. And meditation, mindfulness, and so on, sleep and relaxation training. So, CBT, one example of CBT, catastrophizing, that is the thought, the cognition, my pain is terrible. So, the thoughts, the feeling, and the perception and the behavior is all interlinked cycle. So, in CBT, we work at this level so that it is like a domino effect on all these things. So through counseling, through discussion, through very many techniques, we try to diffuse this cognition. And systematic reviews have reported that catastrophizing predicted negative treatment outcomes. So maybe that is the reason why people relapse, because at the central level, no retraining has been done. The peripheral surgery is done. Then we have this kinesiophobia, where they said, I will get injured. If I lie down, I'll recover faster. So there's activity avoidance and progressive deconditioning and the pain keeps on increasing, where it predicts again poor outcome from for treatment for pain. Again, this ex- exercise and stretching has to be taught to the patient in a graded stepwise manner, and it is again adapted to their pre-existing bodily state. Then we have yoga for endometriosis, which is amazing. There are exercises which give good stretching to the pelvic floor and to the lower abdomen, and they really help to release a lot of that cramping and stress which is there. And we have mindfulness and relaxation techniques. It's a meditation. Again, meditation triggers the vagal reflex, relaxation reflex. Then we have the deep breathing exercises. Breathing is again highly correlated with a state of relaxation, guided imagery and meditation, progressive muscle relaxation. And so all these techniques actually help to uh, control the pain, reduce the stress, and improve emotional well-being. Then we have very important is shared experiences, where I feel somehow in India this thing gets neglected, where if there is a group of patients who can share, it's a very powerful support group and they really learn from each other. It reduces isolation, there's reassurance, practical advice, and it can be local or online communities, and the patients can be advised to go here. And so here the conclusion is that biopsychosocial model is widely accepted as a better way of understanding patients with complex medical conditions, that by recognizing that patients have biological, emotional, and social needs, all three can be addressed, the care is better, more stable, and long lasting. And so there is a vital role of counseling in endometriosis. Thank you. Okay.
Thank you so much, ma'am.
Okay.
It was a very insightful session, and I'm sure we all have gained a lot of understanding about the pain in endometriosis and what it feels like, why it happens, and how the counseling can really help. It was truly an eye-opening talk. Any questions we have for this talk for ma'am? No. Shweta ma'am, you want to say anything?
It was very nice talk, ma'am. I think it really, we only think about the hormonal treatment and maybe the surgery, but there is much, much more beyond that, which I think, as you have described, and so much in depth about the pain, which we probably, as physician, we don't see patient in totality. We just think about the surgery and the hormone treatment. So I think it's a very good talk for the clinicians also, a step ahead, thinking about the patient as a whole. And I think we have wonderful experts also, maybe Dr. Amita, Dr. Ashima, all can give few comments. Anupama is also here with us.
Richa is there?
Geeta ma'am has
Richa is
joined.
there, yeah. Dr. Richa, if anything you want to add, because we have so many good counselors with us.
Geeta
So
Khanna ma'am has also joined, if ma'am
yeah.
wants to say.
So Dr. Richa, Dr. Amita Puri, I think she's joining from.
I think Dr. Poonam had presented it really very nicely. And the last point which he had picked up, like having a support group, that is the,
Yeah.
most important thing. Because
Hmm.
how much ever we say, whenever we see na, people around us having the same problem which we are facing,
Hmm.
somewhere we, tend to fall into this trap ki, हाँ, ठीक है, I am not
Hmm.
the only one.
Hmm.
Because generally
Hmm.
we have that thing in our mind, na, कि मैं
Yeah,
ही
yeah,
क्यों? Why
yeah.
only me?
Yeah. I
So
think the
this
whole
is,
concept of support group is very much lacking here in India. I think
yes,
maybe abroad people don't talk to their, but they have a support group where they can share this thing, which is definitely somebody who is undergoing the same problem. They can connect better with those similar
yeah.
people, with a similar background. So that is
Actually,
something. Hmm.
Exactly, support groups in US and all other places, they are very well
Hmm.
in place, and it
Hmm.
makes a lot of difference to that kind of, we feeling. One can share and talk about these issues. यहाँ
Hmm.
पर sometimes we don't know, some many times,
Hmm.
and or we feel that
Hmm.
we are the only ones who are going through this. And
Hmm.
then there's that psychosocial cultural milieu where we have the elderly ladies saying कि हमारे time में तो ऐसे नहीं था or something,
Hmm.
yes,
Hmm.
very true.
kind
Yeah,
of
yeah, yeah.
also
Hmm.
we are facing in many ways.
Yeah.
And
And what
this line which you have told Dr. Amita, it throws a very bad emotional impact on the patient. Very bad.
Yeah. Uh,
Very true.
and that is where we do sound therapy and sound in this. My book has also come up, The Power of Three. I'll share that in the group also. The Power of Three, psychotherapy, hypnotherapy, and subconscious energy healing therapy. So, Sehat.
Wow.
So this is what we do, say her subconscious energy healing therapy, and that is how it is really works beautifully, especially in in these issues. And yes, we have got very good results with these using these therapies.
That's nice. Really nice. Moreover, educating the patient about the pain which they're having, like how, like if we can say with an example, like agar fire alarm baj raha hai, so that means it's pain. But agar wo constant pain hai, to fire alarm har time to nahi bajega na, so it will become weak over the period of time. So giving that sensitivity to the patient also might be of help to deal with the pain part actually,
There
physical pain.
is a whole education module which has been developed.
Yeah, definitely.
Talking about neuroplasticity and that how rapidly it's not only in the early stages of life that the brain relearns, but at any stage, as soon as there's a change in sensory input, the rewiring starts happening. The neurogenesis also happens. So I wish I had showed that data. I thought there won't be time, but it was done on thousands of. It was a huge pilot study across USA on
Mm.
module, and the result was like worth it. They saved so much money and time. इनकी शॉर्ट बस हो गया खत्म, बात कौन करेगा इनसे, you know.
Very
Mm.
true.
But
Very true.
really a very long cut. It's a shortcut which turns out to be a very long cut.
Mm.
Mm.
Okay. So, any questions we have, Soumya, in the chat
And-
box?
No, we don't have any questions, ma'am.
Uh,
We can
so-
just, so on behalf of the organizing team, I would like to extend my heartfelt gratitude to our esteemed speakers for sharing their invaluable insights on endometriosis and counseling. It was truly inspiring for everyone and a great learning. Thank you all for being a part of this.
Thank you, Poonam ma'am. Thank you. I think
Thank
that is
you.
possible
Thank you
because
so
of
much.
your encouragement.
Yes.
So I think it's a different kind of CME which is needed, because that holistic type of thing, we normally don't do in our as a physician. So it's a joint effort. It's always better. We never thought of doing a counseling session for endometriosis, but it is so very much needed. That chronic pain which never ending actually. So thank you very much.
Thank you. Thank you so much.
Thank you, Dr. Shweta. Thank you,
Yeah,
Dr. Poonam.
thank you. Yeah. Okay. Chalo, let's
Yeah, log out.
close this
Yeah,
session.
bye, ma'am.
Thank you. Thanks
Thank
everyone.
you,
Yeah.
everyone.